Hi guys. Okay, so we covered TBI, just the basics, the hematomas, not other ones. So as I said, look over the PowerPoints for coup, contra coup, focal, primary injuries, and then watch my video for the hematomas, and then you'll be tested on those. In terms of Alzheimer's disease, so let's open this up, take a look at this. It's going to be case study number 38. But before we do that, oops, wrong one. So before we do that, I just want to simply review some of the concepts. So Alzheimer's, can you diagnose it? Can you truly diagnose it? No, you cannot. The only time that you can really definitively diagnose Alzheimer's is postmortem. So you have to actually do an autopsy. They haven't come up with, at least that I know, any method to diagnose prior to that. They can look at the brain, they can do scans, they can see the atrophy that has occurred. A lot of the diagnostic features are really like symptom based. So Alzheimer's is, as we said, by definition, let's go over something simple. It is a progressive degenerative disorder that attacks the brain's nervous cells and neurons. So let's come back to function. And even if I covered this in another video that you guys might have watched, we're just going to simplify it. And these are some of the things that I expect you guys to know. Real basic. My my rendition of the brain is amazing. It is so accurate. Okay, that's what the brain looks like. There's different parts, right? There's also the other portion we call the little brain, right? And then there's the brain stem. And let's do this as nicely as possible. That's not so nice, but this is as good as it gets. Okay, so we have what are the major parts of the big brain? What's the big brain called? So testable features. We're going basics. We're not going to go really detailed. The cerebrum, right? The big brain is cerebrum. What is the little brain? Cerebellum. What are the three parts of the brainstem? Midbrain, pons, medulla. The pons and the cerebellum are actually embryonic structures. They grow together, and so they're really connected. So this drawing doesn't do it justice. But that really looks like the brain. Done a lot of dissections. So the frontal brain, what is that associated with? Well, that's associated with social norms, social context, your behavior, your ability to actually not so much interact, but withhold, right? So if you're thinking something, you don't say it or blur it out. You kind of like think about it before you say it, right? It also contains the motor cortex. So this little slice in the middle is the central sulcus. So gyri is high, sulc down low. That means the gyrus or the gyri of the brain are the elevated portions, and then the sulcus, the sulci, are actually the portions that kind of slit downward. The more you have, okay, I do have to tell this joke because we had a group of MIT alumni, and it was wonderful at the med school. And so they're extremely intelligent, right? And who am I teaching them? And it was just alumni coming visiting through the anatomy lab, and we had a joke. And so my joke was, I walked up to one of the cadavers, and they're intellectual, so it's always fun to play with people that are super smart. And so I said to one of the women, I said, okay, so you have to answer logically. Everything I give you is a feed in. I said, well, men have larger craniums, right? So she said, yes. Okay, so the larger the cranium, the larger the brain, right? So she said, yes. I said, well, if there's a larger cranium and a larger brain, that means there's a bigger intellect. Yes. I said, so men have larger craniums. Therefore, they are smarter than women. It was shocking. And she actually, I said, by logic, you've said yes to all the questions. So that answer should be yes. She's like, okay. And I said, but you know what? Women are a little convoluted, right? Guys, they walk into the store, they know what they want. They go from A to B, they buy it, right? Women, we could have our shopping list, right? As soon as you walk in the store, that's it. There's a sale. It's something that you don't need to buy, but it's a sale. Must buy it, right? So then you walk around. So you take a convoluted path everywhere. I'm like, okay, And by the end of the shopping experience, you've forgotten what you were supposed to buy. So you have to go back. So women, I asked her, women, we're a little convoluted, right? So the guy standing next to her said, yes, yes, I agree. Women are convoluted. I said, well, the brain is kind of like a woman, has a lot of convolutions, a lot of up and down. The more convolutions you have, the more surface area, the more cells you fit in, the smarter you're going to be. So by definition, actually, women, because we're so convoluted, we're smarter. So on that note, just remember that. That's not going to be tested. So the sulcus, the central sulcus has two divisions. It has a one in front, right? So you call it precentral gyrus because it's elevated. Precentral gyrus. And it is raining right now outside, but I'm going to continue doing this. And it has the primary motor cortex. And then the one behind, this is a part of the parietal lobe, has the primary sensory cortex, right? So this in the back here is sensory. And this is called the post-central gyrus. Oh my goodness, I am getting rained on right now. So post-central gyrus, precentral gyrus, understand that frontal lobe is associated with social norms, social context, as well as motor function. Parietal lobe is associated with sensory function. Okay, you should know all of this. It's very simple. And then this guy, temporal. It's right here, right? Temporal. So the temporal lobe sits right by the ear. It's where you hear everything. So it's auditory information. But you have to process what you hear. So in addition to just to auditory sensation, you actually have receptive aphasia. So there's an area called Wernicke's. And in the frontal lobe, there's an area called Broca's. So if I damage this, let's say I have a middle cerebral artery occlusion, and I damage on my left side, majority of people are left-sided, right, left brains. And if I damage those centers, then Wernicke's is a receptive. It receives the information, it processes it. And Broca's is actually your speech center. So if I damage Wernicke's, then I'm going to have what they call receptive aphasia. If I damage Broca's, then I'm going to have expressive aphasia. If I damage both Wernicke's and Broca's and the associated fibers, then it's going to be global aphasia. It's just I'm not going to say as simple as that, but we're going to simplify it down to that. So temporal lobe is for audition, right, hearing. It also has the Wernicke's, right? And then if you look at occipital lobe, yes, it is raining. Yeah, okay, occipital lobe is for vision. So you guys should know those different parts. There's something in here that's hidden underneath the temporal lobe. It's called the insula. And the insula actually...
You're talking about what?
No. Go. Go, go, go. I'm not. No, this is the brain. I'm trying to teach the brain. So it has the basal ganglia. And we will talk about the basal ganglia shortly. Basal ganglia initiates movement. And there's actually substantia nigra. There's some other nuclei that are found in there. But if you've heard substantia nigra, you think dopamine. Lack of dopamine production would bring you to the concept of Parkinson's. But we're not doing Parkinson's right now. We're just doing a brief overview. Cerebellum, little brain. I want you guys to know that that's for coordination, balance, right? So equilibrium. And then the brainstem. The brainstem is really like your last resort for breathing. It has your breathing centers, it has your cardiovascular centers. So when we talked about hematomas earlier, right, and we talked about the different types, any increase in intracranial pressure, any compression inside the brain, because it's a solid container, it's going to push out the foramen magnum, and the foramen magnum actually has the brainstem. If I compress the brainstem, I compress the respiratory center. I compress the cardiovascular center. I can put the patient into respiratory failure, right? Because I'm compressing it. So that's what you worry about. And I think that's as simple as we get. So this is the norm. What happens with Alzheimer's? You have atrophy of different parts of the brain, right? There's the limbic system. The limbic system is associated with two things. It's associated with memory, and it's also associated with emotions. Because emotions and memory are deeply connected, right? The stronger the emotion you have, for something, the longer you'll be able to recall and remember that. So this is normal. Let's go through the case study and quickly assess what we're looking at. So it's a read through. This is actually a lot of just background information for this patient, understanding that they do have some memory loss and it is progressive. That's what this is trying to show you. So I will read quickly through it. You guys have access to this to read on your own slowly. Chief complaint: I got lost in the grocery store. My children think that I need diapers that old people have to wear, right? RM: 83-year-old woman presents to geriatric clinic for routine visit, accompanied by two oldest daughters. Parent was diagnosed with probable Alzheimer's disease. Why? Really simply, you can't diagnose really until postpartum. No, did I say postpartum? I meant post-mortem. Post-mortem. My goodness. Okay. 9 years ago, children reported short term memory loss and several cognitive manifestations. So, the first thing to go, as you guys can recall, is short term memory. It's the formation of new memories, limbic system, and some of those pathways like hippocampus, parahippocampus, amygdaloid, right, or amygdala. Those guys, when they start to atrophy, you lose the ability to uh, recall new information, but you still have a lot of long term memory intact until the disease itself progresses. Okay, so simply put, let's get through this. Taking walks in neighborhood, she lived for about 45 years, got lost. Neighbors helped her home more than one occasion. About the same time, children friends noticed several changes in personality. So remember, we said if you have atrophy of the frontal lobe, then you're going to have changes in personality. You no longer have the ability to inhibit or, I guess, respond accordingly, right, to the social context, or at least it's diminished. Let's not say you're not able to. And then previously enjoyed flower gardening, she lost interest in. Complete clinical workup, neuroimaging revealed no significant new medical conditions that were causing neurologic manifestations. So as I said, diagnostically, postmortem, right? So everything that they see, the only time that they're really going to see it is if it has progressed to something where physically you see the enlargement or you see the gaping portion inside of the brain, right? Look at the difference between this. We talked about surface area. The more surface area you have, the more cells you can fit. When you start to atrophy, you start to lose surface area and therefore brain cells, right? Same thing again. And then one of the key terms that I want you guys to recall, since you guys are familiar with this, make sure you understand that Alzheimer's, one of the key identifying portions is neurofibrillary tangles and amyloid plaques. And as a side note, from what I've read through some articles, it has been studied that statins, HMG-CoA reductase inhibitors, right, for cholesterol or hypercholesterolemia, those statins are associated with a reduction in the onset of Alzheimer's. It doesn't prevent it, but it um, pushes the onset a little bit further from when they suspect it might happen with that individual. Okay, so you got that. Let's get through, keep reading. So scored a 25 out of 30 on full steam mini mental status exam. She was started on Tacran, but adverse effects, intolerable, nausea, vomiting, etc. Her medication was changed to donepezil. What is donepezil? It's Aricept, right? Aricept helped significantly with both memory and mood for several years. And then about 4 years ago, they noticed another change, right? Because the disease was continuing to progress. Does donepezil do anything with the progression of the disease? No, it doesn't stop anything. Only thing it does is help to preserve some of the memory. Um, Not only had previous manifestations become more severe, she also developed new features of Alzheimer's, right? Difficulty with numbers. So all her long-term memory. So at the beginning, it was short-term memory that was lost, and then it progressed to long-term memory, wasn't able to do AIDLs, and then even games that she knew for 60 years. She began to show signs of poor judgment. You can read through that, like leaving the house without a coat on a cold winter day, or even going to the store in a nightgown, as well as a small kitchen fire that her neighbors were able to put out. At this time, she was tested for a new systematic disease, but no significant abnormalities were detected. other than mild case of iron deficiency anemia. So again, like I said, even the imaging, unless it's progressed really severely, you're not going to see it. You're not going to see it until after. And moving on, CT scan of brain, moderate to severe cerebral atrophy. So they can't diagnose Alzheimer's based on that, but they can be suggestive of Alzheimer's, right? And then her score for the MMSE uh, reduced from 25 out of 30 to 18 out of 30. Shortly after, daughters sold home, moved her into live with the family. Two oldest daughters shared caregiving responsibilities. Youngest son, within past 6 weeks, she's demonstrated multiple sudden outbursts of anger. So it's really progressing to atrophy of a lot of the different systems within the brain. Shopping earlier, she had an outburst and became violent with the store. Several customers tried to help, but she had thrown several tomatoes at the store manager, broke into a violent rage, checkout again because grapes she purchased um, fell out of the bag and onto the floor. So you're seeing that the disease is progressing. That's all that I want you guys to get for this case study. So you guys can look at this, and they're considering SNF. Hypertension, 20 years. Episode of neurolithiasis, 2 years. Gout, 2 years. Hypercholesterolemia. And then, of course, she is using the statins, so I'm not sure. Maybe her disease was held off longer than it would have if she wasn't using the statins. Plantar fasciitis, occasional constipation, which is okay. And then both parents deceased. Father died from CVA, mother died from Alzheimer's. So suggestive of familial association, right? Brother had heart disease. Sister also had Alzheimer's. Again, familial association. Lives with daughter, widowed for 14 years. Does not smoke, drink alcohol. History, recent infection. Reports occasional bladder incontinence. No complaints of chest pain, shortness of breath, etc. So I know that you guys are familiar with this. It's just for me to rehash. Anytime you have someone that has a full bladder, right, especially women, they don't have the same signs as I shouldn't say full bladder, I should say a UTI, right? When you're younger, you're within your 20s, 30s, 40s, 50s, whatever, your signs would be maybe frequent urination. You'd notice some tenderness or a little bit of pain in the suprapubic region. But with elderly, they don't have that sensation, that response. So the question I have for you, or at least the reminder I have for you, is we're trying to determine the difference between um, dementia, Alzheimer's, and even uh, my brain has just gone blank. So delirium. That was the other word. I had to pause for a second. The word sometimes, you know, when you're thinking too fast, they don't always come out of your mouth fast enough. So Alzheimer's, dementia, and delirium, you guys should be able to distinguish on basics. And then meds. So donepezil, Aricept for her Alzheimer's, right, for memory. Allopurinol for the gout. Pravastatin is your HMG-CoA reductase inhibitor. So that one's for your cholesterol. Lisinopril is your ACE inhibitor. That's for the hypertension that she has, right? And then Ensure is dietary intake needs. Ibuprofen, pain meds, deoxysate sodium for constipation. And let's move on. Let's make this quick. So, elderly woman in no acute distress becomes less confused with slowly repeated questions, simple explanations, difficulty, a significant tick in the upper lip. Okay. And then blood pressure a little bit high, respirations unlabored, 15, and pulse is within normal too. Pale, sensile, okay, poor skin turgor, so she might be dehydrated, right? Multiple minor ecchymosis, so bruising on the forearms, no other lesions, abrasions. Heat within normal limits, temporal dentures present, buccal and pharyngeal membranes moist. And then what else? Neck supple, so no JVD, so no heart issues that we're looking for. So we're kind of saying that everything else seems pretty normal for her. The one thing that we're looking at is cognitive function. Everything else, no murmurs, no AFib, soft, non-tender. Trying to possibly rule out any other factors that could be affecting her memory and her cognitive distortion right now. And we're gonna say that there is nothing positive. If you guys see it, let me know. Pinprick, neurologic, DTR is intact, negative Babinski. So we know that they're trying to rule out like upper motor neuron lesion signs or any kind of stroke that might have occurred with her, the facial drooping, all of that, just to rule it out and ensure that you guys are following along. I know from all of you, this is a simple case. So we're going to end it right there. Let's see if there's anything that you guys might need to know. 135, 145, 3.5 to 5.0. 95, 105, bicarb 22. Maybe this one's a little bit high. Maybe she has some renal function issues, but it doesn't look like BUN and creatinine are elevated. And then I don't see any GFR. So, wait. Almost done. No. And then
with the fire
okay.
thing.
So you guys can look through that. Enjoy.